tips, talking a little bit about the classification of inherited colorectal cancer, and then finally really the role of endoscopy in the management of the colorectum, and the talk will specifically be about that and not all the other manifestations. So just a few general points. It's not just about the colon. With the exception probably of serrated polyposis syndrome and familial colorectal cancer type X, they all have other extra chronic manifestations, and you need to be aware of that. It's not just your patient that's at risk, it's the whole family. And there's no doubt at all that these patients are best managed in specialist units, multidisciplinary, with good endoscopists, good surgeons and good geneticists. And finally, specifically for here, we want high quality, comfortable procedures. These patients have to go through this for all their life, starting from teenage years. You put them off on the first time, it's goodbye, and they develop cancer. So this is a very simplistic classification, and really based on historical classifications, divided into non-polyposis and polyposis hereditary colorectal cancer. And for the non-polyposis, what we now call Lynch syndrome, previously confusingly HNPCC, and also familial colorectal cancer type X. The polyposis syndromes will be defined as to the type of polyp that's involved. So probably the ones we're all familiar with, the adenomas, FAP, the more recent MAP, and the super recent polymerase-associated polyposis, or PAP. And I won't talk anything more about that because we have no data really about its phenotype or how to manage it. The next group is the so-called hematomatous polyposis syndromes, and I guess Poitzschegers and juvenile polyposis syndromes are the one people may have heard of. There's the rarer P10 hematomatous tumour syndromes, which are Cowden syndrome and Benay Riley-Ruvalcaba. They're vanishingly rare. I've seen 2 cases ever. There's no data, so I'm only just going to briefly touch on those in the summary slide. And finally, serrated polyps, or the serrated polyposis, and Evelyn's covered that for me already, which is great. So Lynch syndrome. It's the most common inherited colorectal cancer, and I'm sure anyone who's involved in colorectal MDTs will be seeing this on a regular basis, whether they know it or not. The population carrier frequency for mutations is said to be about 1 in 3,000, and it's responsible overall for 3 to 5% of colorectal cancer. So how do we diagnose it? Well, historically, most people will have heard of the Amsterdam criteria, the 3 first-degree relatives, 1 under the age of 50, of course, across 2 generations. Now, this is very useful clinically, if you can remember it, but it's not particularly good because, in actual fact, on the original criteria, of those that fulfilled it, only 45% actually had Lynch syndrome.